you so much, Nivedita. So, today I think it's a great opportunity for me to speak on this very interesting forum. And, I was told to choose the topic of my choice, and rarely do you get an opportunity to speak on something which you really enjoy speaking on. So, this is going to be, I almost give a talk every, all other day. But this is something which is going to come from my heart, and you'll learn a lot of things I have learned over a period of years. So it's going to be very, very interesting. So, what I'm going to talk about is unifying theory for the pathogenesis of diabetes mellitus, and more importantly, its practical applications in day to day clinical practice. Now, why unifying theory? We have all heard about unifying theory, field theory in physics. This is like what Einstein and all the great physicists of their time tried to combine. They tried to say that what are the unifying forces? Is there a formula by which you can explain all the forces of the universe? Unfortunately, Einstein in his lifetime, nor were the other physicists in their lifetime able to achieve this. But the thing is that with diabetes mellitus, we have an understanding of the pathogenesis with which we can unify the various forms of diabetes and try and understand it from one single context. Now, the first thing you have to understand and first thing you have to learn is to unlearn. Sometimes over a period of time, we learn certain things which may not be the right thing to learn. So sometimes we need to take a step back and unlearn a lot of things. And today, in this next 30 minutes or so, I want you to forget the buckets of type 1, type 2 diabetes. We are going to move away from buckets and move towards what I would like to call a spectrum. So, diabetes mellitus in all its forms, in my opinion, is a spectrum of the disease rather than single buckets where which we put the patient into. So, we often tend to label a patient as type 1, we tend to label a patient as type 2, we tend to label a patient as pancreatic diabetes. But what we forget is that these are all parts of one spectrum rather than having one just a single bucket. And very interestingly, sometimes patients can move across the spectrum, which is the very interesting part. So, if in one line you ask me, what is the unifying theory for pathogenesis of diabetes mellitus? It's very, very, very simple. It's diabetes mellitus is an imbalance between insulin resistance and insulin production, that is beta cell function. To understand this is very simple. Now, we all know why this is very true. It's because this holds true for every other endocrine disease that we see. Every other endocrine disease that we see in clinical practice is an imbalance between the hormone production and the hormone action. And that is what ultimately really defines any endocrine disease. And diabetes mellitus is an endocrine disease at the end of the day. So whatever holds true for a hypothyroidism or for a parathyroid or for a testosterone also holds true for diabetes mellitus. Only thing is, the resistance part is relatively rare in other endocrine forms, whereas it is center stage to diabetes mellitus. Now, get this perspective. The body tries to maintain a very steady state of glucose control. Again, fundamental to understanding endocrinology is to understand the fact that body always tries to maintain homeostasis. Homeostasis means steady physiological state. Your temperature remains constant. Your blood pressure tends to remain constant. Your pulse rate tends to remain constant within a narrow band. Same way, your glucose, blood sugar, also tends to remain constant within a narrow band. Now, if you don't believe me, try putting a continuous glucose monitor in yourself. Now, assuming that you are not suffering from diabetes mellitus or even pre-diabetic, if you put a continuous glucose monitor, CGM, you'll find that almost all your sugars are within one narrow range. And believe me, because I've done this several times on myself, and I'm thankfully not suffering from diabetes. And I don't intend to. as well. So the point is that the body tries to maintain the glucose in a very narrow spectrum, right? In a very narrow range. And this range is where body will try all its efforts to maintain that. And that is what is known as euglycemia. Now, there could be two situations. For maintaining euglycemia, you need a set of hormones. The most important, the center stage of all these hormones is insulin. Of course, you have other players in the field. So you have the glucagon, you have epinephrine, you have the other hormones, cortisol, thyroxine. All these hormones play a minor role, but the major role, the main actor of a play is insulin. And if the body is not able to produce insulin in adequate quantity, that is beta cell dysfunction, then again you have hyperglycemia. And the body is able to form insulin, but the insulin is not able to act as well as it should be. That is what is known as insulin resistance. Again, you have hyperglycemia. So all the forms of diabetes that we are going to discuss now, in the next slides, we are going to take all our buckets, all these type 1 and type 2 and everything, and try to fit into a theory. And we'll see how it really works perfectly, magically. So all forms of diabetes at some level is an imbalance between insulin resistance versus a beta cell dysfunction. Let's move ahead. So like I said, the body tries to maintain a state of euglycemia. At this stage, you have insulin resistance is equal to beta cell function. Okay, so if you put it in a mathematical formula, insulin production is equal to insulin resistance. And if this state is achieved, you maintain a perfectly normal blood glucose. That is euglycemia. Now, what happens when you have hyperglycemia? So any form of hyperglycemia, you will have the insulin resistance more than beta cell function. Now, when I say insulin resistance is more than beta cell function, I don't always mean that the insulin resistance is high. The insulin resistance may be normal and the beta cell function may be less, or the insulin resistance is high and the beta cell function may be normal. Get my point, right? So to say, if one let's say one pen I say is short, I always say this pen is short in comparison to my other pen, which is tall. Right? Doesn't mean that this is the shortest pen in the world and doesn't mean that this is the tallest pen in the world. What it means is that my black pen is shorter than my red pen, but perhaps my blue pen is taller than my red pen. Right? So what I'm trying to tell you is that in any situation, either the insulin resistance is high and the beta cell function is normal, or the beta cell function is reduced and insulin resistance is normal, or it could be both. Insulin resistance is high, beta cell function is low. So that's the basis of hyperglycemia or increased blood sugar. Now, conventionally, we classify diabetes into three major forms: type 1 diabetes, type 2 diabetes, and other forms of diabetes. Now, this is the traditional bucket. Like I said, we'll take this bucket and put it into a spectrum. And I'll try to first make you unlearn or try to see the conventional diabetes classification from our fundamentals, and then we'll try to reclassify that in a more different way. Okay, the other forms of diabetes are pancreatic diabetes, just to name a few. There are many. Gestational diabetes, steroid-induced hyperglycemia, now COVID-induced hyperglycemia, lipodystrophies, LADAs, MODIs, everything, right? Okay, so now let's first talk about type 1 diabetes. Now, just to tell you, this slide, you might not be able to see it completely. So all you can do is pinch to zoom. So you can pinch to zoom and you can see the slide much more clearly. So what happens in type 1 diabetes? Now, type 1 diabetes is the classical form of type 1 diabetes is a classical example of beta cell dysfunction. It's in fact not the most classical form. In fact, the most classical form of beta cell dysfunction would be when I completely remove the pancreas. There is no beta cell, no pancreas, no beta cell, no insulin. But close to that, you have another form, which is beta cell dysfunction, which happens with type 1 diabetes. Now, what happens in type 1 diabetes is that you have autoimmune damage to the beta cell. So by some mechanism, you have damage to the beta cell. And this damage to the beta cell prevents the beta cell from releasing insulin. Right? So this is the classical form of a type 1 diabetes. But what happens to insulin resistance? In most cases, the insulin resistance is normal. So this is the situation where insulin resistance is more than beta cell insulin production, but insulin resistance is more or less normal and the beta cell function is low. But let me tell you that even in type 1 diabetes, the insulin resistance is often not normal. Insulin resistance is in fact slightly higher. If you've seen a patient with type 1 diabetes in your practice, or if you see these patients often, always ask them, how were you diagnosed to have diabetes for the first time? And they'll often tell you that the first time I developed fever, I had respiratory problem, I developed COVID, something like that. There's always a history of a trigger. And this trigger produces infection or inflammation. Always remember this point. This is an important pearl to remember is that insulin resistance, when you have infection or inflammation often leads to insulin resistance. This is very, very, very important. This is a key fundamental. This is what happens. We see a lot of, I practice in a hospital setup. So I see a lot of patients who have infections, who have respiratory tract infections, who tend to have diabetic foot infection, who have urinary tract infection. All these cases, whenever they have infection, the blood sugar goes up. So even at home, their blood sugars are normal, but when they get admitted, the blood sugars go up. Why do they go up? Because infection produces a sense of insulin resistance. So sometimes what happens is a patient is having an autoimmune damage to the beta cell, but still there is homeostasis being maintained. But as soon as they develop infection, the insulin resistance goes up and the beta cell is not able to catch up to this insulin resistance, and these patients go on to develop type 1 diabetes. So even in type 1 diabetes, initially at the time of diagnosis, they tend to have a sense of, they have a tendency to insulin resistance. Now, sometimes you would have also heard about this phenomena called honeymoon phase. So after some time, with good glycemic control, a patient with type 1 diabetes often goes off insulin. Insulin is often stopped in some of these patients for a brief period of time, and this is a honeymoon period. And after that brief period of time, the patient goes back to requiring insulin. So this is a brief honeymoon period. Now, this happens in a lot of patients with type 1 diabetes. What happens is that with you corrected the infection, you've broken down, there is a tendency to what is known as glucotoxicity or glucose toxicity. This glucotoxicity breaks down, the insulin resistance comes down, the beta cell recovers slightly, right? But it's enough to overcome the insulin resistance, and the patient maintains a euglycemic state for a brief period of time. But as the disease progresses, the beta cell function keeps declining. The patient goes on to develop a full-blown type 1 diabetes once again. So this is how a type 1 diabetes fits into our picture. If you see this slide, right, this is a very beautiful cartoon showing on the left side, you can see a normal beta cell mass, a normal islet of pancreas. And you can see the green portions in this islet are the beta cells. You can see what happens in type 1 diabetes. The beta cells, you can see the green cells are less. So when these patients are diagnosed for the first time, they continue to have some amount of beta cell function, you can see. But it is substantially reduced, as you can see from the picture on the left. But as you go ahead, if you go towards the right, you can see that almost no beta cells are seen. And this is what happens in an advanced form of type 1 patient. So you can only see alpha cells, which are blue in color. You don't see the beta cells. Same way, you can see the picture below, where, like I said, there is a triggering event, often an infection or inflammation, which triggers this entire process. The patient goes into a stage 1, then stage 2, and then stage 3, which is the symptomatic form of type 1 diabetes. So this is what happens in a patient with type 1 diabetes. So even in a patient with type 1 diabetes, even though it's a classical example of a beta cell dysfunction, even they tend to have a little bit of insulin resistance. Great. Moving on, let's move to the type 2 diabetes spectrum. So this is the other end of the spectrum, right? Even now, remember, this is not the extreme example. The extreme example of insulin resistance are conditions like autoimmune insulin resistance syndrome, or conditions which are called lipodystrophies. We'll discuss that lipodystrophies later in a few slides. So let's first take a pre-diabetes situation. Now, a pre-diabetes situation is a situation where you have euglycemia, right? Where you have, again, the blood sugars are normal. Patient is pre-diabetic. Patient's blood sugar is slightly increased, but they're not increased to the level of diabetes. So you can say to an extent you are maintaining status of euglycemia. Now, in this situation, the insulin resistance is actually high. The patient has higher insulin resistance. But the beta cell also increases its capacity to produce more insulin to match up for this insulin resistance. So what happens in these patients? You have increased insulin resistance, but you have also increased beta cell function. And again, insulin resistance matches the beta cell function and the patient maintains euglycemia. This is a pre-diabetes situation, right? And in this situation, you tend to have hepatic insulin resistance, peripheral insulin resistance because of obesity, hepatic insulin resistance because of fatty liver, and then clinically you will find patients having acanthosis nigricans and so on and so forth. So this is basically the pre-diabetes situation where you tend to have a near euglycemia, but this near euglycemia is maintained because you have insulin resistance high, but the beta cell is able to catch up with the insulin resistance. Now, what happens when the disease progresses? So you have early type 2 diabetes. In early type 2 diabetes, now you develop hyperglycemia. Now, to understand early type 2 diabetes pathogenesis, let me tell you about animal models about diabetes, right? So when they want to have animal models for type 2 diabetes, what do? They remove certain parts of the hypothalamus in mice, and these mice, they remove the areas which tend to produce satiety. Now remember, when you eat food, after some time when you eat food, you tend to become, your body says that I had enough, right? I don't want to eat more. So you have satiety. But this satiety is what stops you from eating. So if I remove that part of the brain, now if you are interested in this, there's something known as hypothalamic obesity. We had written a very interesting paper on that. You can search for it, hypothalamic obesity. We had a case report on that. We also said that, Kumkaran, right, perhaps had hypothalamic obesity, because you see what the stories of Kumkaran were. They used to say that, he did not have any satiety. So he'd keep eating. So this is what they do to this lab mice. So they remove their satiety center and they are given unlimited food. So you give them, it's like party time for this mice, right? So you remove their satiety center and you give them unlimited food. So they keep eating. Now they keep eating, they start becoming obese. They start gaining weight. Now what happens? The mice start gaining weight. By gaining weight, they start becoming catch up for this insulin resistance. The beta cell keeps producing more and more and more and more of insulin. So at different stages of time, now all of these mice do not develop diabetes. At different stages of time, they keep eating, they keep becoming more obese, and the insulin keeps being produced. But at some point of time, at different stages of time, different mice, they start developing diabetes. So at some point of time, one mice's beta cell gives up. I don't want to do this anymore. They stop producing more insulin. The mice develops diabetes. Then there's another mice whose beta cell gives up. Then another mice develops diabetes. So this is what happens, right? So ultimately, what I'm trying to point out is that you know about rate limiting step in an enzymatic reaction, right? What is the rate limiting step in diabetes? In all forms of diabetes, the rate limiting step is beta cell function. As long as your pancreas can produce more insulin to match the insulin resistance, you will not develop diabetes. This is the fundamental process you have to understand. As soon as your as soon as your beta cell gives up and it is not able to match up for the insulin resistance, the patient develops diabetes. And this is exactly what happens in type 2 diabetes. So in type 2 diabetes, the insulin resistance is increased, but the beta cell function is not able to match up because of this. And because of this, they go into a situation called early type 2 diabetes. Now, there are certain forms of early type 2 diabetes where they present as a flatbush diabetes. Flatbush is a region in New York, close to Brooklyn, where you had a lot of poor African American kids. And at one point of time, they observed that a lot of these kids go on to develop a severe form of ketosis, form of diabetes, and they come with diabetic ketoacidosis. But you give them insulin for some time. After some time, they go into remission. So what happens in certain patients is that when you have people giving up, so sometimes your boss scolds you and you leave your job next day. I'm not going to this place, right? So that's sudden. In some cases, you plan your exit, right? So you give your resignation, then you're called by the HR, then you give your notice period, and then gradually leave, right? So in a lot of patients with type 2 diabetes, you have the beta cell gradually giving up. So beta cell will give you a warning. I'm going to give up. I'm going to give up. I'm going to give up. eventually gives up and you develop hyperglycemia. But in certain cases, the beta cell just gives up suddenly, right? Suddenly that function is lost. Suddenly you have insulin resistance severely overwhelming the beta cell function in the patient. It's so severe that patient even goes on to develop diabetic ketoacidosis. So this is what happens in early type 2 diabetes. And then you have this glucotoxic cycle which happens. So with more blood sugar, you have more glucose in urine, the patients develop more polyuria, polyphagia. You have increased calorie intake to compensate for that. So you're losing glucose in urine, you want to eat more. More glucose means more sugar means more beta cell dysfunction, less insulin, more hyperglycemia. So this creates a vicious cycle of glucotoxicity, and this cycle then needs to be broken for a patient to really go back to normal state. What happens in a state of late type 2 diabetes? So when the type 2 diabetes progresses over a period of time, the insulin resistance then reaches a state where it is static. So insulin resistance reaches a static point, but the beta cell function continues to decline slowly over a process of time. And that's why you see remember type 2 diabetes is a lifelong disease in a lot of sense. Of course, you have patients who go into remission, right? A lot of patients, but at the same time, if the beta cell is not preserved, it continues to decline over a period of time, and then patient continues to, at some point of time, you will have patients come and say that I have, I could manage my diabetes with one tablet, but now I'm not able to manage with even 3 tablets, right? So it's a progressive decline of beta cell. This is what happens in a late type of diabetes. Moving ahead. So this is again sequence of events, like I discussed. Again, in terms of, you see the islets of pancreas. So you can see on the left, you can see robust islet, but in early stage, remember, you can see the green color is increased slightly, right? And later on, as the insulin demand increases, you can still see beta cells. You can clearly see, and you can see the beta cell have not declined too much, right? But they'll gradually decline. But what you see is this, fibrillatory purple things you see. These are amyloid deposits. So as beta cells start declining, more and more amyloids start getting deposited in place of beta cell, and this leads to gradual and permanent decline of the beta cell over a period of time. So early on, you're able to, it's not permanent. You can reverse it to a lot of extent, but as the disease progresses, it tends to create a situation of permanence. Okay, moving ahead. So as I talked to you about, this is what I wanted to show you. That remember, type 1 and type 2 diabetes are extreme ends of spectrum, but it's a spectrum. It's not a bucket, right? So you can see here in this very beautiful diagram, you can see that what you're seeing is set of buckets. So what you can see is, you from top to bottom and bottom to top. So you see, type 1 diabetes tends to occur at a younger age, type 2 more with age advance. If you see the obesity also, the pyramid is inverted. So type 1 generally tends to occur in non-obese, whereas, with obesity, you tend to have more of type 2. Metabolic syndrome, HLA-DQB1, which is a marker for insulin, for autoimmunity in type 1. You have the other markers, which are, FTO and other markers, which are part of type 2. You have systemic inflammation, you have autoantibodies, you have T cells, C-peptide decline, insulin requirement, all of these. But see, what is important is that all of these are present in all forms of diabetes. So whether it's a type 1, type 2 LADA, you have, though the frequency, the tendency, the amount is less. You can see type 1 even in elderly population. You can have insulin requirement even in type 2 diabetes. You can have some C-peptide decline in type 2 as well. So there is everything, but the point is that it is at different levels in different forms. So type 1 and type 2 are extreme forms, whereas the other forms of diabetes fall somewhere in the middle of the spectrum. And in fact, there are forms of diabetes which are even more extreme than type 1 and type 2, which we'll see in a few minutes. Okay, now let's discuss. So we understood that how type 1 and type 2 really are. So type 1 and type 2 are basically, type 1, just to summarize, is a form where beta cell dysfunction predominates, and type 2 diabetes is where you have the insulin resistance predominate, right? But there is some amount of insulin resistance even in type 1, and there is definitely beta cell dysfunction even in type 2. So like I said, it ultimately boils down to the fact that it's a spectrum. Now, other forms of diabetes, and with this you will understand this process even better. So let's talk about gestational diabetes, right? So gestational diabetes is a condition where you have, the patient was euglycemic, the patient was having normal sugars before pregnancy, but during pregnancy, somewhere in the middle of pregnancy, somewhere at about 24 to 28 weeks, the patient develops diabetes. Now, why does that happen? This is classical to what we discussed in that early and late diabetes. So what happens is the patient had euglycemia before pregnancy, but the beta cell had to some extent declined. So you had the beta cell which was not very robust. So you have little bit of insulin resistance. So you had this situation where both things were compensated each other. So the patient had normal blood sugar. But what happened in pregnancy? As the pregnancy advances, the insulin resistance advances, and with the increase of insulin resistance, at about 24 to 28 weeks of pregnancy, the beta cell is not able to match up with the insulin resistance which happens because of pregnancy, and because of that, the patient develops hyperglycemia. This is what happens in gestational diabetes mellitus. And if your beta cell function was very good, you are like those mice who keeps eating and yet does not develop diabetes. So if your beta cell function is very good, then even this insulin resistance which is increased in pregnancy, the beta cell is able to match up, and that's what happens in most of the normal pregnancies. But in certain women, the beta cell is not able to, because of this beta cell not being able to match up, these women go on to develop gestational diabetes. And as soon as the delivery happens, the blood sugars again become normal. Why does it become normal? Because now that insulin resistance is gone, so that insulin resistance reduces, and with the sudden fall of insulin resistance, the beta cell is now able to match up with the insulin resistance, and the patient goes to normal blood sugar. But gestational diabetes is like a stress test for diabetes, and those women who develop gestational diabetes are almost 5 to 7 times more likely to develop type 2 diabetes in future, because if their insulin resistance increases because of some other factor, maybe another pregnancy, maybe increased weight, obesity, maybe postmenopausal status, and these women will go on to develop diabetes in future. So that is gestational diabetes. What about steroid-induced hyperglycemia? Another something we see very commonly with in clinical practice, similar to gestational diabetes. So again, as long as the patient was not on steroid, the patient maintained euglycemia. But when you give steroids, you increase the insulin resistance, and this increased insulin resistance exposes the poor beta cell reserve. Patient develops diabetes. Now the steroid is stopped, the insulin resistance comes down, the beta cell is able to match up, and the patient goes to normal blood sugar. So this is what happens in steroid-induced hyperglycemia. And in some patients, the insulin resistance becomes permanent, it becomes continuously high, especially when the steroid is given for a long time and the patient continues to maintain diabetic state unless treated. What happens in pancreatic diabetes? Now, pancreatic diabetes is also known as type 3C diabetes. Very interestingly, in an advanced form of pancreatic diabetes, let's say somebody who has chronic pancreatitis for a long time, beta cells are completely depleted, or somebody has a pancreatic cancer, or somebody has a pancreatic surgery, somebody undergoes a Whipple surgery, something like that, you have obviously less beta cell, and hence you have developed diabetes. So, right, it's very simple to understand. Less of pancreas functioning, less beta cells, more likely to develop diabetes. But it is not as simple. Even in pancreatic diabetes, in early forms of pancreatic diabetes, remember in acute pancreatitis also you have diabetes. And this early acute forms of diabetes, you tend to have increased insulin resistance. So in some of these early pancreatic diabetes also, sometimes when you give this patient metformin, the patient goes on to maintain normal blood sugar. Very interesting, right? So in early forms of pancreatic diabetes, you tend to have insulin resistance, but as the pancreatic diabetes progresses, you tend to develop more beta cell dysfunction, and eventually the patient goes on to require insulin. Right? So even within pancreatic diabetes, you tend to have a spectrum. Moving ahead, COVID-induced hyperglycemia, very classical. We saw a lot of these patients. So you have insulin resistance. What produces insulin resistance in COVID? Inflammation, steroid use, obesity, right? Remember, obese patients with COVID had higher mortality. On the other hand, what produces poor beta cell function? COVID-19 virus itself had a tendency, it had ACE2 receptors which are present in the pancreatic beta cells, with which the virus gained entry into the cells, and because of this entry into the beta cells, it caused damage to the beta cell, and you develop this COVID-19 virus-induced diabetes. And remember, a lot of the patients who develop diabetes after COVID-19 had permanent diabetes. We have seen this very commonly. We have a lot of these patients in clinical practice now, and some of these patients had poor baseline beta cell reserve, which kind of added to the problem. So this is how. So COVID-19 hyperglycemia was actually a very classical form of diabetes where you had both the spectrum being easily visible to you, and this in a very severe form. And in fact, the idea of this unifying theory actually is very classically shown in COVID-19 induced hyperglycemia. Moving ahead. lipodystrophy. Now, this is a very rare condition, but we do see that in clinical practice. And in lipodystrophy, this is a condition where you have some reason why you have destruction of the adipocytes, right? And this produces a very severe insulin resistance. It's a pure insulin resistance syndrome, right? It's a condition where you have pure, in fact, you have mainly peripheral insulin resistance. And in this case, again, a lot of these patients with lipodystrophies do not develop diabetes mellitus. But some of these patients with lipodystrophy go on to develop diabetes. Where does the difference lie? The difference lies in the beta cell function. So if they're in lipodystrophy, if their insulin resistance keeps increasing and the beta cell keeps matching up to this insulin resistance, you don't develop a problem. But if their insulin resistance is high and the beta cell is not able to catch up, the patient goes on to develop diabetes. And this type of diabetes is actually very difficult to manage, because even if you give insulin from outside, it's not going to work, right? So it's a very complicated form of diabetes. Your insulin, you have to give in very high doses, or you need to use other strategies. Nowadays, of course, SGLT2 is a good option because it's completely bypasses the insulin pathway. What is LADA? LADA is actually, in fact, the best way to understand LADA is that LADA is actually a type 1 diabetes. LADA is nothing but a form of type 1 diabetes, but it's a slowly developing type 1 diabetes. So what happens is, in all patients, the beta cell destruction, so there is an autoimmune, see, the characteristics of an autoimmune disease is it's not predictable. In some patients, there would be, I believe there would be patients who will have CAD antibody in their body, but will never develop type 1. There'll be some some children who have CAD antibody and they develop diabetes very early on, within 1 to 2 years of life. Whereas some people develop type 1 diabetes much later in their life, even though they may be carrying the CAD antibody. So when you develop a type 1 diabetes very slowly over a long period of time, generally by definition after the age of 30, that is what is known as LADA, or latent autoimmune diabetes of adulthood. So LADA is actually basically a form of type 1 diabetes. You have beta cell dysfunction, but again you have the preponderance of insulin resistance also in these patients. And as the age advances, what happens? The insulin resistance of the patient increases. Because the insulin resistance increases, the beta cell is exposed. So sometimes you have, even in definition of LADA, they say that patients should be on oral anti-diabetics for 6 months before they require insulin. And why this definition is required? Because see, what happens is, in the first 6 months, actually we are treating the insulin resistance, and then the beta cell dysfunction is not able to match up, and then you require insulin, right? So that is what happens in a patient with LADA. Okay, what about MODY? We'll not discuss MODY. I think this is again an area where I'm very interested in, and perhaps in future we might have a discussion on MODY in more great detail. It's a cluster of disorder with different patterns. Most of the time, you have beta cell dysfunction again in different unique ways in these patients. So we'll discuss that in a later class, right? So this was the conventional diabetes spectrum, which you understood. So like I said, diabetes, think of it as a spectrum and not a bucket, or not a different watertight buckets. No, they are not. So the time has now come to really give you a new classification of diabetes. Now there are certain ideas which have come. There are in fact 3 ideas. We'll discuss those 3 ideas. But in fact, I personally am not satisfied, except for one of the 3 ideas. I think has some merit. The other ones still, I would think, is not the best way of characterizing diabetes. In fact, I feel that we should try and remove the buckets. We should try seeing patients in a more therapeutic approach. What type of therapy you will give to this patient, that should be the priority, rather than trying to label a patient as a type 1, type 2, type 3, C, whatever, right? So, however, there were attempts made for new classification of diabetes, new clusters, new buckets again, unfortunately. And what are these attempts, and what do these really suggest? So Elquist et al., this is from Scandinavia, from Sweden. They came up with novel subgroups of adult diabetes in 5 to 6 different clusters, right? So they came up with different clusters of types of diabetes. So they give 5 clusters. The 6th one, which then later somebody as an editorial added. So there are 5 classical clusters of diabetes which they give. They said the first is severe autoimmune diabetes, second is severe insulin deficient diabetes, third is severe insulin resistant diabetes, fourth is mild obesity related diabetes, and fifth is mild age related diabetes. Now, why I like this? Because yes, they have also made buckets, but these buckets are not watertight. They are not type 1, type 2, others. No, they are still, you have the tendency to shift between these buckets and go to different buckets depending on the clinical circumstance. But at the same time, it's still a bucket, right? And based on our model, they still fit into our model much very beautifully, right? So what is severe autoimmune form of diabetes? This is basically type 1 or LADA, where there is autoimmune destruction of beta cells. So if you see insulin resistance versus beta cell dysfunction, this falls into the beta cell dysfunction category. And what I really like about this is that they classify type 1 and LADA as the same. And this is what I also believe, because type 1 and LADA are actually the same disease. It's only that the intensity of the disease is different, right? So it's type 1 and LADA, which is severe autoimmune diabetes. Second is severe insulin deficient diabetes. And severe insulin deficient diabetes, here you have autoimmune biomarkers are negative, but you tend to have beta cell dysfunction. And typically, your pancreatic diabetes will be classified as severe insulin deficient form of diabetes, especially when it is over a long period of time. So this is actually, again, in the spectrum, if you see, this is again insulin beta cell dysfunction, which is the main problem here. But it is a situation where you tend to have autoimmune markers which are negative. Moving ahead, you have severe insulin resistant form of diabetes, where here the insulin resistance is prominent. Beta cell dysfunction is also prominent. So both the things are there, but the insulin resistance is the primary driver of the disease process. And these patients tend to have higher risk of diabetic nephropathy. And this type of patients we see not uncommonly in India, right? So you have high insulin resistance, low beta cell dysfunction, but insulin resistance drives the process. And this happens in patients who have more visceral adiposity, and these patients are also more likely to develop diabetic complications. Then you have mild obesity related diabetes. This is a condition where the insulin resistance is just above the beta cell function. So the beta cell is able to catch up to a lot of extent, but at some point it just stops, right? And insulin resistance also stops. And if this patient keeps increasing insulin resistance, the patient goes into bucket 4 to bucket 3. But if the patient maintains at this level, the patient develops what is known as mild obesity related diabetes, right? And then you have the fifth category, which is mild age related diabetes, where with advancing age, you have slightly increased insulin resistance in everybody, and you have slightly reduced beta cell function in everybody. So this is basically age related issue, where again the diabetes is generally mild. Just giving 1 or 2 medicines, oral medicines, you are able to do it. In fact, a lot of the patient you can control with dietary modifications itself. So this is how this is the Scandinavian or the Sweden classification for diabetes by Elquist et al. And if they look at their own cluster from Scandinavian countries, they had, in the various buckets. So you had again majority of the patient falling into mild age-related diabetes. That is a cluster 5. But the reason is that they have longer lifespans there, and tend to have a lot of patients, and a lot of these patients are on socialized medicine healthcare. They come into attention. In India, of course, you will not find this type of pattern. In fact, the cluster you will find in India more commonly, I'll just show you in a few minutes. We have a similar study from India also. Again, you have a lot of cluster 1 patients. So Scandinavian countries have a lot of type 1 patients. So you can see 14% of patients from this group actually were type 1. Whereas in India, believe this is very just somebody who is a postgraduate student planning for a DM entrance exam, the most common cause of diabetes in India is type 2 diabetes. Second most common cause of diabetes in India is pancreatic diabetes. It is not type 1 diabetes. Type 1 diabetes is third most common. So type 1 diabetes in India in terms of prevalence is less common than pancreatic diabetes also. But in this case, you can see type 1 is more common because in Scandinavian countries, you tend to have more type 1 diabetes. Now you have this Indian cluster. So Dr. V. Mohan et al. Actually came up with these clusters. Mainly he classified, so he removed type 1, he just made sub-classifications of type 2 diabetes, and which are very similar to the Scandinavian classification. So he said you have severe insulin deficient diabetes, right? So these are basically, again, insulin deficiency, again, beta cell dysfunction is a major problem, right? So again, and some of these patients can have some amount of pancreatic involvement as well. Then you have the insulin resistance obese diabetes, which is very similar to cluster 4 of the Scandinavian countries. Then you have combined insulin resistance and deficient diabetes, which is similar to cluster 3 of the Scandinavian countries. And then you had mild age-related diabetes, which is exactly same as the fourth classification, the fifth cluster of this. So very similar clusters, but again, in his cluster also 35% of the patients who had mild age-related diabetes. But in practice, you don't see this very common because they don't come to clinical attention very commonly unless you do an epidemiological study. The first, second, and third are the ones who will come to your clinical practice. So to give you a picture of this, a severe insulin deficient diabetes patient will be something like, they'll come with, severe beta cell dysfunction. So they'll come with, polyuria, polydipsia, weight loss. They will have, the weight will be reduced, such kind of clinical picture. The insulin resistant obese patient will be exactly the opposite. The patient will be obese, there'll be weight gain, all these things will be there. And then you have combined insulin resistance and this, where again, this is something you see in clinical practice. As endocrinologist, I see this category very common, where you have both the things which are bad and the patient, these are the groups who should develop a lot of severe complications. So the third classification, which I feel is, in my opinion, the best way of classifying, is what is known as A beta classification. So A is basically autoimmune marker and beta is the beta cell function. So autoimmune marker, whether they are present or absent, the autoimmune markers typically are GAD antibody, you have IA2 antibody, IAA antibody. So these are ZNT8 antibodies, these are various antibodies. These are all markers of autoimmune disease or autoimmune diabetes, which is basically, in definition, type 1 diabetes. So when you have autoimmunity present and the beta cell is not functioning, so your beta cell deficient, this is classical type 1 diabetes. When you have autoimmunity present and beta cell function is still present to some extent, this is LADA. Autoimmunity is negative, but beta cell is negative, right? So you have no autoimmunity, but the beta cell is not functioning. This is the cluster 2, which is severe insulin deficient diabetes, similar to what clusters we are seeing with. It should still be classified technically as either type 2 or type 1B diabetes. But again, there is a confusion in this category. So again, it's not a great idea to put it in any of those buckets. And autoimmunity negative and beta cell function is present. This is a classical type 2 diabetes. So I feel this is a better classification of classifying diabetes because it gives you some guidance to how you treat this patient, right? So 1, 2, and 3 categories you will treat with insulin. The fourth category you can treat with oral antidiabetics. But the fourth category, the A negative, beta positive, is the category which is the most likely to see you in clinical practice. These are the most common patients, right? So this is the A beta classification of diabetes. Now, so this was the first part of the talk, that is the pathogenesis. But now we'll come to the more important part of this talk, and that is basically the clinical approach, the clinical implications of this. Okay, so what are the clinical implications of this? So first thing you have to see is, how do I classify my patient? So the patient who is in front of me, where does this patient fall into Om Lakhani spectrum, right? That is the question, right? I'll tell you how you'll classify your patient, right? Like I said, these spectrums are necessary because the treatment that you'll give to this patient depends on where the patient stands in the spectrum, right? So you will classify that based on clinical cues, on a test which we do, which is known as mixed meal stimulation test. I'll just discuss this, and based on autoimmune markers. Now, if you have the facilities available for number 2 and number 3, great. But if you don't have the facility for number 2 and 3, don't have a good lab backup, you need to rely on clinical cues. And that's why it is very important to be a clinician. It is very important to be something like a Sherlock Holmes who picks up this little signs and then makes the right treatment call. Okay. So what are the clinical cues? So I told you, see, one end you have insulin resistance, other end you have beta cell dysfunction. What are the clinical markers of insulin resistance? What are the clinical markers of beta cell dysfunction? So clinical markers of beta cell dysfunction is mainly catabolic. Catabolic means breaking down, right? So the patient with beta cell dysfunction will come to you with history of unintentional weight loss. They'll come with the 3 classical P's: polyuria, polydipsia, polyphagia. They'll have fatigue, they'll have change in vision, and they'll have diabetic ketoacidosis. So whenever you have any of these features, the patient is having beta cell dysfunction, which is predominating. On the other hand, a patient who is having insulin resistance, which is predominant, this is a group where you have an anabolic situation where the patient typically has weight gain, central adiposity, so the patient will be obese, patient will have insulin resistant signs, that is acanthosis nigricans. If you see their ultrasound, you will find fatty liver, and if you see the cardiac marker, if you see the echocardiography, you will have HFpEF, that is heart failure with preserved ejection fraction, or often they'll have diastolic dysfunction, which is remarked in the or left ventricular hypertrophy with diastolic dysfunction, which you'll see in the echocardiography reports. So when you see this type of picture, the patient is in an insulin resistant predominant situation. Now, why you need to differentiate this? We'll come to this in a minute. But this is the group where insulin is the first choice. This is the group where metformin is the first choice of treatment. This is the first important point you need to understand. So then, of course, we'll come to the treatment part. So I'll just hold your thought for this for a minute. The second thing you can do is actually classify the beta cell situation. We do a test which is known as mixed meal stimulation test. We do this in-house in our hospital. However, you can do it. You can develop the same test in your laboratory or in your hospital. I'll tell you how it is. Then, see if you have this facility available, if you can develop it. So what you do is first you measure the fasting blood sugar along with the C-peptide. Then you give a liquid meal, which is a standard meal, which only most of these labs, most of these papers are based on Sustakal. Sustakal is basically from Nestle. It's like your Protein X and all that. But what we use is Ensure Plus powder, which is a similar composition. But the idea is, in fact, this is much more easily available in India. So Ensure Plus is what we use. We give 6 scoops of this powder in 200 ml of water. And after 90 minutes, we measure the sugar again along with the C-peptide. So this is the mixed meal stimulation test. Now, more important is how do you interpret? So this is our interpretation, right? This is not published. We are in the process of publishing this. So this is unpublished thing. But this is the interpretation which we typically have developed and which works perfectly. It has very good sensitivity and specificity in our practice, right? So we, in fact, board are in process of collating the data and publishing it. So when you find the C-peptide, now remember the C-peptide value I have here, I have given it in nanogram per ml. Some labs give it in millimoles per liter. So depending on what lab your value is giving, you can do the conversion. You can see the conversion online. So fasting, if the fasting value of C-peptide is less than 0.24 nanogram per ml, we categorize this as score 5, right? We'll see this importance of scoring. This patient is more likely to have type 1, and then you can see the grading 0.24 to 0.6, 0.6 to 0.1, or 0.6 to 1, and more than 1. Whereas post-meal, if you have, or random, in fact, if you do a random C-peptide also, so if you don't have lab facilities available for all these complicated things, you can do a random C-peptide. And if a random C-peptide is less than 0.6 nanogram per ml, again, this is score 5. Then 0.6 to 1.5, 1.5 to 1.8, 1.8 to 3.3, and more than 3.3, right? So this is the idea. Now you take score of top and bottom and you add it up. If your score is more than equal to 5, it is strongly suggestive of type 1. If it is between 3 to 5, it is suggestive of type 1. So, and 0 to 3, unlikely to be type 1, but needs a close follow-up, and 0 means it is not type 1. So typically, if you find the C-peptide value fasting less than 0.24, automatically it is type 1. Or if you find a random or post-meal C-peptide less than 0.6, automatically label that as type 1, right? Or insulin deficient. I'm not saying type 1 again. Remember, see, I'm unfortunately misclassifying my own way. Basically, you have beta cell dysfunction, right? So this is what it is. Okay. So if you have value more than 5, the patient has beta cell dysfunction, and this patient requires insulin. Okay, going ahead. So now the importance comes of what treatment to use. The third parameter, of course, I have not made a slide for this, but the third one was autoimmune markers. Autoimmune markers you need to test. The only autoimmune marker you need to test in an adult is GAD65 antibody, because this is the only antibody which survives up till adulthood. The other antibodies will most likely be negative. But in children, you need to do multiple antibodies. You have GAD65 antibody, you have IA2 antibody, you have ZNT8 antibody, and you have IAA antibody. And these are available as a package from some of these labs, or you can individually order these depending on the clinical situation. But one you must insist in all patients is GAD65 antibody or anti-GAD antibody, which is available in most of the good labs, at least in Ahmedabad. Okay, so now the question comes, what was the need to classify? The reason is you need to classify this in this way, or you need to spectrumize it in this way, because you need to understand how to treat it, right? So whenever you have a patient in a catabolic situation, when you have a patient who is having beta cell predominant features, like we discussed, the patient has weight loss, 3Ps, diabetic ketoacidosis, change in vision, and if you do the lab test and if you find the total score in the mixed meal stimulation more than equal to 5, this patient is catabolic. If this patient definitely requires insulin. So insulin to dena hi hai. Some of these patients later on you can give sulfonylureas if they have some beta cell residual action, and some cases pioglitazone. But overall, one thing you should definitely give in this patient is insulin. What about patients who have anabolic features? And anabolic features you have where you have weight gain, central adiposity, HFpEF, fatty liver. These patients require metformin or GLP analog or SGLT2 inhibitor, right? So why it is important to see? So when you see one end of the spectrum, the extreme end of the spectrum where you have severe catabolic features, insulin. The other extreme end of the spectrum where you have severe anabolic feature, well, textbooks will say metformin, but I feel that metformin and SGLT2 should definitely be the starting treatment in this group. So why it is very important to subclassify, to spectrumize this patient, is because the one end of the spectrum where you have beta cell loss, which is predominant, this end of the spectrum you give this patient insulin. The other end of the spectrum where you have insulin resistance, which is predominating, you tend to give metformin and SGLT2 inhibitor. So this is how you divide this entire group. And in the middle, you have more beta cell predominant features. You have more likely to use insulin, pioglitazone, sulfonylureas. When you have more of insulin resistance type of features, you tend to give more of GLP analogs and so on and so forth. Of course, pioglitazone you can give it to both the groups, but in early anabolic features you will not give pioglitazone. But later on, in fact, pioglitazone basically works by reducing insulin resistance. So pioglitazone is something you can act in both. But unfortunately, pioglitazone have their own baggage, which doesn't make it a very attractive option. Right? More importantly, it is important to understand when to use insulin. So when you have patients with prominent catabolic features, when you have beta cell depletion features, when mixed meal stimulation score is more than 5, definitely more than equal to 3, consider patient with diabetic ketoacidosis and patient with random C peptides less than 0.6 nanogram per ml. You definitely need to give this patient insulin. Right? Finally, when not to give SGLT2, this is also equally important because SGLT2 are now becoming very, very popular in clinical practice, and you need to understand this point very importantly, because sometimes if you give a patient with beta cell dysfunction, it's SGLT2 inhibitor, you can sometimes trigger the patient going into a euglycemic ketoacidosis, which is a feared complication in this patient. So patients having prominent features of catabolism, patients having features suggestive of beta cell depletion, patient having mixed meal score of 3, patient with diabetic ketoacidosis and C-peptide less than 0.6. So basically I mirrored this last slide to tell you that these patients should not be given SGLT2, right? Rather, they should be given insulin. So to summarize and give you some take-home messages, first take-home message is that the unifying theory for pathogenesis diabetes is imbalance between insulin resistance and beta cell function. And the final common pathway or the rate limiting step is still the beta cell function. And beta cell function drives type 2 diabetes. Second, hyperglycemia develops when you have insulin resistance more than beta cell dysfunction. Now, this could mean either insulin resistance is higher or beta cell dysfunction is lower, or you have both. Third, it is time to revise the conventional classification of diabetes and to see diabetes in clinical practice as a spectrum and not airtight pockets. Finally, you have mixed meal stimulation is a useful test. If you have a fasting C-peptide less than 0.24 or random or post-stimulation C-peptide less than 0.6, it is suggestive of absolute insulin deficiency and you should give insulin. 0.5, using the drug with the prominent feature. So you have more insulin catabolic features or more anabolic features or more beta cell depletion feature and more anabolic feature, you will use the right drug. You need to see clinically whether the patient is catabolic or anabolic and use the right drug for the right patient. Finally, again, if you're interested more in endocrinology, just like you have this very beautiful Netflix, you have something which is a written version of Netflix, you can say to a lot of extent, is our Notes in Endocrinology app. It's freely available on iOS and Android. You can download these and you'll find a lot of notes on similar topics and other topics in endocrinology in very simple question answer format, written by. And if you want to contribute to this also, please get in touch with us. We are open for collaboration also now. Earlier it was this one-man show, but now it's a collaborative app, so you can get in touch and you can download this. So thank you for a patient listening, and again I thank Netflix, the Netflix of medicine, for this very beautiful opportunity, and I hope you learned something very useful. Thank you.